So Shelley Mathis, who is our director of our program and does much more than that. But Shelley, you're on.
Okay, warriors, we are so lucky today to have one of the most distinguished pulmonary specialists in the world, Dr. Naftali Kaminski. Dr. Kaminski is the Behringer Ingelheim Endowed Professor of Internal Medicine and Chief of Pulmonary Critical Care and Sleep Medicine at Yale School of Medicine. Before that, he was tenured Professor of Medicine, Pathology, Computational Biology, and Human Genetics at the Dorothy and Richard Simmons Endowed Chair for Pulmonary Research at the University of Pittsburgh, where he was director of the Simmons Center for Interstitial Lung Disease and Lung, Blood, and Vascular Center for Genomic Medicine. These are very distinguished honors. I think we have attached a link to his bio with the invitation, because I could go on forever about his prestigious background, education, experience, publications, research, but then I'd be doing all the talking. Dr. Kaminski is with us here today to talk about how, as lung patients, and if we should join the reopening of America. So thank you, Dr. Kaminski, for joining us today. You're on.
Oh, thank you. Thank you for the invite. This is, frankly, I cannot think of a better way of spending a sunny morning in Connecticut than meeting pulmonary fibrosis warriors all around the world. It's really exciting. I wanted to start, and this is going to be really informal. I will show some things and some data, but it's not a presentation. So what I want to start is actually speak a little bit on something that the world has seemed to lose attention to, except maybe you, which is idiopathic pulmonary fibrosis or pulmonary fibrosis and the campaign to cure fibrosis. Can everybody hear me well?
Yes.
Yeah. So I want to mention a few things. So although really our attention has been to the COVID-19 pandemic, I want to highlight several things and sort of tell you a little bit about the last 3 months. And basically just March 5th, I was in the first week of March when news about what was going on in China and then in Italy were emerging. I actually went together with quite a few leaders of the pulmonary fibrosis community to a meeting in Naples, Florida. And the meeting was with Three Lakes Foundation to start discussing, and I don't know if all of you know, the Three Lakes Foundation was started by Tom Horvis, and it's basically a fund that aims to really shift and transform what we're doing in pulmonary fibrosis, is move as fast as possible toward more effective therapies. And we were in this meeting during the week, the first week in Naples, in Florida, basically discussion and designing a project. And I just want to say, I don't want to jump the gun. I want to say that the commitment for this project that will really accelerate drugs coming into the field is nobody has forgotten. During that meeting, I was starting to get sort of a feeling that something was really wrong and we were going to get hit in the US. And actually, I cut short my meeting, came back to Connecticut, and just looking at what was starting to emerge from Italy, frankly, I went into sort of my paranoia zone, right? So I've been, I have a military background. I was a soldier in Israel. I have a historical military background. My father was both a sole survivor of his family at the Holocaust as a 13-year-old, but then at 16 actually volunteered in the army to fight the Germans. So the stories of heroism, but actually also being ready for a crisis really go in my family. So the first thing that I came in to Connecticut, I said, the first thing we have to do was to defend our teams. right? If we need to take care of patients, we cannot go walk into the war with sick physicians. And the Department of Medicine at Yale and later the school and the hospital accepted this model. We basically sent everybody home much earlier than most other places did. Anybody that didn't need to take care of patients was basically sent home. We canceled elective procedures much earlier, like New York was hit ahead of us, but we canceled many of those early. So again, we prevented infections. And Yale New Haven and Yale School of Medicine were really amazing in their willingness to do these efforts. You know, they hit your bottom line. You lose money if you cancel procedures and elective things. And we cleared out 3 floors in the hospital, being ready, and extended their capacity so we would have be able, when the surge hit us, to basically almost increase the capacity of our critical care units from around 60 or 50, which is our normal, which is actually around the biggest in the Northeast, or I think the biggest in the Northeast, to we wanted to go to 300. And then we increased our capacity in the hospital dramatically. Our hospital usually has around 1,400 patients. We were able, by canceling procedures and clearing up things, to have around 900 patients in the hospital when this hit us. So we were ready. And here's the thing, and this is for me, it's a little bit almost personal, right? So when people say this is not a serious thing, this is just an exaggerated flu, this is also almost like somebody telling you a tsunami is just a small wave that hits your leg when you're on the beach. If you experience it, you know that you were hit by a tsunami if you survived it. And for us, this wave of patient coming in, you know, and it's scary. The first day it's 1, the next day it's 4, the next day it's 16. And suddenly you're hit, right? And at the height of the surge, we had 400, 500, 700 patients just with COVID-19 in our hospital, right? Luckily, we were ready. In our medical intensive care units, we reached 200 patients. We had to actually take physicians who are not experts in critical care and bring them into our teams. And people volunteered. People didn't know if they'll get paid extra. They didn't know if they'll actually be protected. This was for me an amazing test of our community. We turned our operation rooms into intensive care unit. As you know, in an operation room, you put the patient to sleep during the surgery so you can ventilate them. So we didn't want to be in a situation that we would need to select who is going to be ventilated or not. So we basically turned our operation rooms into intensive care units. This was not easy because these ventilators are not built to ventilate somebody for 3 days. They're built for a few hours. This required a lot of both the dedication of the physicians working and the nurses and the technicians day and night. But the other thing, it required a lot of, and that's people underappreciate, a lot of technical skills. The people who do the information technology, wiring the room so we could monitor 200 people with critical care. Like, just to explain to some of you, if one of you organize a project, if I needed to double the size of a medical intensive care unit, it would take 3 years to do it. You will need architects and the state approving it and money and budget approved. These are millions of dollars. This thing was done at Yale New Haven Hospital within literally a few days. So the dedication, and I think, you know, people like to speak about a little bit dismissively about our country, like we're not good anymore, we're not strong. What we saw is amazing dedication, you know, and it doesn't matter. This is people, every walk, right? If you look at New Haven, is although nobody thinks about it, is actually the average city USA. So we're exactly at the middle of USA in terms of age, racial, income. We have these big gaps in income. So we have everybody. And everybody was in this fight. And I thought this was, you don't want to have stress tests in your life. You don't want people suffering or sick. But if there is a crisis, that's the way you go into it. There were challenges. For instance, again, and the reason I'm telling you this, and I'll get to it in a second, is because, again, there is this tendency to feel that everything is sort of slowing down and getting better, and there's a lot of misinformation about the severity of the disease. And it's really important that people know the sort of the facts on the ground, not the newspaper piece. During the first 2 weeks in April, my main job was basically to be, I don't know how you'd call it, a super secretary, right? Because every day and sometimes every few hours, we didn't know what we would be missing. You run out of this drug, and then you're going to run out of masks, and then you're going to run out of gowns. And then some nurses are getting burned out, and your physician. So I'm really glad, and I don't want to jinx myself, we didn't have a single physician in our teams, and almost no single nurse that got infected in the hospital. So we were really happy with that. That said that we were ready. We saw that as we took care of the patients with COVID-19, we started seeing that many of the things that people told us were wrong. So, for instance, although it's true that the disease is really lethal in older, mostly men, unhealthy men, and it went through nursing homes and assisted living facilities in Connecticut, and really places that were not protected, people just passed away very quickly. But it also hurts the people that are not expected, right? And at a certain stage, like there is a treatment that's many of you know, which is called ECMO, in which we let the lung rest. And we sort of recirculate the blood through and oxygenate it to keep somebody healthy. At a certain stage, our people on ECMO were between 25, we had 9 patients of ECMO. They were between 25 and 40. This is not the people that the media said are going to get hit by the disease. If you would have asked them a week earlier, would they get sick? They probably would laugh at you, right? Most of them, surprisingly, are really doing well now, but this is speaking a course of like 6 or 8 weeks. But they're not yet back to, they're just breathing on their own, they can walk, but their process is still long. One of the, we've learned, and that's why and that has to do with all of you, I think I've learned several lessons to this. One is, you actually want to be a little bit more careful than what is told to you, right? So population health and epidemiology works on numbers and on averages. So when somebody tells you it's now safe, the question is, how safe is safe? And the other side was, so the people who were obsessive about social, I don't like the word social distancing, I prefer physical distancing. But the people who were obsessive about physical distancing from the beginning, the people who started wearing masks before you were supposed to wear masks, are the people who were safer. If we look at the way the disease spread, the people who started avoiding public transportation before, and I think one of the reasons, if we look at the patients that we had, and we had a lot of them, if you look overall, we had over 3,400 patients going Yale New Haven Hospital. There were very few of them with, actually very few with IPF, very few with immune deficiency. very few with other chronic conditions that we're always worried of. And the reason that I think these communities already take care a little bit, like the transplant, the post-transplant patients. You know, we instruct people after transplant that that's it. Looking good is not an issue for you. You know, you need to keep your safety. So if there's a flu, if flu is in the air, you're going to wear a mask and ask other people to wear a mask near to you. So I think actually some of our populations who didn't have a false sense of security actually did very well. Before we go on to sort of the recovery and back to life, I want to say a few things actually about what has happened these 3 months. So again, as I told you, there is a big drama. All of our physicians are working. They're working shifts, 12 hours days, 7 weeks days in the MICU, 7 days off the MICU, which means not that they're at the pool, but that they're doing other administrative things. Research was completely shut down initially. Then we got approval to do research related to COVID-19. And my group is involved in several such projects. We're trying to understand what happens in the blood of the patients with COVID-19. We are developing a method to take human precision cut lung slices that we obtain from mostly from normal lungs that were rejected for transplantation. And we try to infect them with the virus and see if there's a real difference between old people and young people, between different things, and also try some therapies. One of the drugs that I developed in my lab, we had a discovery 2 years ago about the fact that thyroid hormone, a hormone we all have in our bodies that regulates our metabolism, can help the lung recover. And actually, I think that this should be tested. And the paper we published was about pulmonary fibrosis. But we also discovered that this molecule seems to protect the lung from injury. And we were able to put in a very rapid process, and it's now under evaluation. It went through one evaluation at the FDA. There's going to be another evaluation at the FDA soon. We're going to start a trial in COVID-19 patients to try to see if you could prevent the severe lung injury. But on the other hand, remember, we don't have to do research to maintain relationships and connections. So several things have happened with regard to pulmonary fibrosis, which is sort of good news. And again, just for due disclosure, I've been involved in these things. I've been a consultant and had a financial interest, but I think it's still important as good news. So one thing is drug development in fibrosis continues. There's a company called Pliant that was started a couple of years ago. They have a unique way of trying to stop fibrosis by inhibiting a molecule called TGF-beta and in the lung. And just to show you that there is interest, I'll just share my screen in a second. Can you see my screen?
Yes.
So Pliant decided, despite the fact that the whole world was focused on COVID-19 and we don't know what is with the economy, they decided to go public because they need money. They have a drug. They are going to do trials. And, hopefully you all know what is an IPO, initial public offering, where a company basically becomes public and sells stocks to the market. And basically they were able, during this time of crisis, to make an IPO and basically sell it actually higher than what they asked. And they were able to raise almost $140 million through the IPO. And then another, quite a lot of money through a collaboration with Novartis. So this is good news. Well, definitely good news to the founders of Pliant. Good for them. But for us as a community, it's important because they're going to do a drug trial. They're sitting on the drug. They're ready. they're a new player in the market. And for us, any good shot on goal helps us, right? Every trial helps us. We've learned now. We have 2 drugs that are FDA approved. We have several drugs that are coming through. And this is another sort of one of these newer drugs. As I always say, you have a drug that the first 2 drugs are never perfect, but the next one do well. So this is one good piece of good news. The other good news, and hopefully you can see my screen, actually has to do with my research. And this is several years ago, Jose Herasso, Imre Noth, Skip Garcia, and myself and others identified a gene signature in the peripheral blood of patients with IPF that seems to predict outcome very well. So it can distinguish between people who are going to go down very quickly and people that are going to be stable. Now, you all know what this is important, right? You all had or many of you had the shock was getting diagnosed, going on the internet and seeing 3 to 5 years median survival. But you know, the numbers on the internet don't tell you the fact that many people are very stable for a long time. And some will crash and burn quickly. And it's really important for those who crash and burn quickly to have access to either therapeutic drugs or transplant, or frankly, if they don't want either one of those, even just, you know, being with family and planning the future. So we think it's really important to predict outcome. Because we're academicians, we were really smart at showing that this signature worked. We showed it in 6 cohorts of patients all around the world. In the UK, in Germany, in the US. We even had Harvard and Yale the first time that we have the same result in those 2 institutions. So really a good result. However, when patients would call me and say, is this test available? I would tell them, no, it's not. And the reason is because although I'm, I think, a sort of a modest or okay physician scientist, I'm not a developer. I'm not an implementation person. And I was glad to see that Veracyte basically has been looking at this signature for a couple of years and decided to basically collaborate with Yale on trying to find a way to really commercialize or bring this as a test. Hopefully this works. You know, the standards of, again, clinical testing are very tight, but I think if we have more tests that are really specific to pulmonary fibrosis, our ability to tell people who really need transplant, you need it now. People who don't need it, you can wait. Our ability to guide people to different types of trials is going to be really important. So I think that's hopefully you share my view that that's a piece of good news. The last piece of good news I want to mention is another project that comes from my lab, which is the IPF Cell Atlas. So you've all had the experience of many of you, that you hear the name IPF, and the first thing is this adjective that should be removed, the idiopathic. Because the idiopathic basically tells you we don't know what causes it. This is true. We don't necessarily know completely what causes pulmonary fibrosis, but we actually know quite a lot about it. What we don't know is how the disease develops in the human lung. And what we don't know is how the different cell populations in the human lung change during the course of fibrosis. And the reason this is important is because the lung has a lot of cells. There's almost 40 cell types in the lung. And I'll show you one image which I think will illustrate this. This will come up in a second. This is sort of a big So you see it? So on the image or sort of the movie, you can see the different types of cells in the lung. We can stain them. And the thing is, what people tend to forget is fibrosis is not the disease of one cell in an organ. It's the disease of the organ. Cells are these living units that build an organ. Your brain has multiple cell types that make you think and remember and be alive. And your liver allows you to clean on the toxins, again, by multiple cells. And the lung is the same. There's a combination of different cell types that do the function of the lung. And fibrosis is not because one cell goes wrong. It's because the way these cells speak with each other, how they interact, changes. So to understand and to be able to actually reverse fibrosis, not only slow it down, we need to almost reprogram the relationship of these cells. And that's what we did. And the first thing to do it is you need to profile all the single cells in the lung. So several groups have done it. It's completely grassroots, 4 or 5 groups. The image that you sort of see circulating around is basically all the cells in the human lung in 70 individuals. So every little dot there is a cell, and the color is the different cell types. So you can see that almost the human imagination, like for us to even understand what's going on there, is really complicated. But so we now profiled, I'll just show this just to be fair. There's 5 groups that did it, and our group profiled 300,000 cells from 70 individuals. And together with the other groups, we now have 500,000. So we now have a really good map. We're starting to get a sense of how cells are abnormal in the human lung. And this will allow us to start fixing them, or at least design intervention that will fix them. But the main thing is that I don't think that one person can understand this. I don't think that one team can resolve this. So the most important thing we did, so this is going to be published, it's accepted to Science Advances, I think in somewhere in July, there will be a big announcement that there are 2 papers showing, identifying new cell types that are well, not specific, but they're enriched in the pulmonary fibrosis lung that may really explain what is going on. And I'll be glad to come back and speak about it. That's not our topic today, but I thought that you all will be excited to hear about this. And I just need to fix one thing. So the most important thing we did was actually create this cell atlas, which is publicly available. And every person in the world, literally every person in the world, and I'm going to share my screen again, can click on www.IPF Cell Atlas. And you could go there and look, and there's multiple data sets, Kaminski, Rosas, Banovich, Bisharin, Lafayette. And you could look, and you could go and actually, if you're interested in a specific gene, you could look it up. If you want to know, again, mostly it's going to be less important for you, but really important for industry, right? So all of you know that fibrosis means that there is an increase in collagen, right? But now these are the different cell types. Red is IPF, blue is control. And you can see which cell type has a lot of collagen. And for instance, this unique cell population that we've discovered, which we could call aberrant basaloid cells, which is really important for pulmonary fibrosis, has a lot of this thing. And there's a lot of other things we could look at. There's multiple features. There's other tools for analysis. People can compare data sets, can explore it. So the reason I think I'm mentioning this is because, from my point of view, this is a tool to accelerate discovery, right? Because now it's not only me looking at the data. It's not only people reading my paper and knowing what I'm interested in, but everybody in the world can go in and pick a molecule they're interested in. I can just type in anything I want and search for it. And now I can know if it's high in pulmonary fibrosis, in what cell type. So every drug company in the world that has a compound can use it. And guess what? We've had 3,000 people clicking on this website, doing 8,000 individual searches. So definitely, like, this is big for industry, for academia, this is big. So that's I think the part of the good news on pulmonary fibrosis. So I think now we want to start sort of thinking about coming back to life, right? What is safe and what is unsafe? We don't, when people in my family asked me what I think was were the safest periods and the unsafest periods, I give them, and you know, that's the advice I give my mother who lives in Israel, is when things are stable, even at the high tide of epidemic, it's actually safer for the regular person because you're sort of, you know, when there's no disease, you behave one way. When there is a pandemic, you sort of get into your mode and you shelter down at home and follow rules and you're good. The most dangerous periods is when the thing starts and when the thing ends. Because this is where you're breaking boundaries and nobody actually knows how to behave. And again, as somebody with military experience, there used to be an old saying in the Israeli army, and I think also in the American army in Vietnam, was that the days of ceasefire are really dangerous. Because there is a ceasefire and you tend to relax a little bit and you stand up and then you get hit and you don't want to be the person who dies when the peace accord is signed. So I think this is really important for this community. Slow down, there's no rush. You know, you'll be perfectly well if you don't go to a restaurant one more month. So how do you think about that in a more, and I want to show you something just that I think in a second I'll show it.
Sean scolded me for going to that restaurant.
Did you say we were the only one there?
So how do you protect yourself? And I'll go very quickly about these things because there's research about what is really protective and what is not, right? So unlike 3 months ago or 6 months ago, I think we have a good feeling what helps. So one is, if we look, and let me see if I can find it. And I'll, in a second, bring it up on my screen. I'll share my screen in a second, and I hope I can explain it. It's not that important, but this is a big report that was published in Nature that basically looks at different countries in the world and look what are the individual policies that really worked. And what the first thing we see is this is, and hopefully you can see my, you know what, I'll do one more thing which will allow me to be more understandable. So if you can see here, it's the infection growth rate without policy. And that's China, South Korea, Italy, Iran, France, and US. And basically you see that the infection growth, that's the red, increases a lot. This is in logarithmic scale, so the percent growth per day is around between 30 to 70%. So that's if you don't do anything. 35% per day means that within 3 days, you double the number, right? That, yeah. Now here's, if you took all the policies that were instated in the countries, and again, there's a big difference, and this is really important. So China, week 1, of course, there's no effect. Week 2, there's a reduction in infection. Week 3, there's a complete reduction in infection. So this shows you that when you implement the policy, of course, it has no effect the first day. But within 14 to 21 days, you need to start seeing a change. And then if you look here, South Korea, Italy, Iran, United States, the moment the policies were implemented, there was a big decline. And the decline was actually big. This is 26% reduction in infections, 31 in the US. And remember, the US is mixed numbers because certain regions implemented policies and others didn't. If you look at the individual policies, I don't know if you could look at this. These are papers, and I'll put something on Facebook soon. I just didn't get to have a time. You can see that certain things like travel ban, at least in China, had no effect. The emergency declaration and home isolation had an effect. And if you look at the other things, no gatherings, travel bans, every country was slightly different, but many things had a big effect. And in the United States, actually, social distance was the biggest thing. Now, when we look at it, and this is not in this model, when we look at it a little bit more carefully, actually in the United States, probably the biggest thing was actually the masks, the universal masking policy. And I think the delay in the masks, especially in New York, which is so crowded, cost us a lot. Now, here's an interesting thing. And again, these are numbers, so you have to always be careful. But this group, what they did is took the same information and modeled the actual deaths from the disease, and then what would happen if you didn't implement policies. And these numbers are shocking because we have a tendency as humans to sort of say, oh, nothing happened, not a big deal, right? Or this, but look at this. Spain could have gone from 25,000 dead to 500,000 people dead. They really saved, 450,000 people. Belgium, 110,000 people saved. We don't have the estimates here to the US. So this could have been, even with the measures that were taken that were not perfect and were too slow, a lot of lives were saved. A lot of lives were saved. And I think we have to, while we don't necessarily agree with every action, we have to give credit to the public health officials who insisted on taking action in every country, despite the political implications, despite ideology. In most of the world, public health officials were very, professional. And that's what we need. We need civil servants that care about us. And I'll show you one thing in a second, which is very confusing because there was one country in the Western world that actually didn't take extreme measures. And this is Sweden. And they had a rationale. They thought they would go to herd immunity. And the concept of herd immunity is an interesting and sort of misunderstood concept. Because the idea of herd immunity comes from vaccine, not from natural immunity. Because in vaccine, when we vaccinate people, if we can cover around 70 to 75% of the population, the rest of the population is going to be protected. So that's a completely different, so that's why the whole argument between anti-vaxxers and vaxxers and forcing people to vaccinate their kids if they go to school comes from this simple principle that you have to hit a certain threshold of immunity to protect the community. And the people who were not vaccinated or the people who accidentally, the vaccine didn't work. When you apply it to nature, herd immunity is meaningless because we know that populations get wiped out by disease, right? Native Americans in the US, right? And during the history of the US, a random interaction with viral carrying individuals caused terrible diseases. So by the time you would say herd immunity was accomplished, right? And so, um, so in Sweden, they had this concept of trying to see whether herd immunity and whether they avoid hurting their economy, but by instituting sort of protective policies. And they had the rationale, right? And also the Swedish society, it's not as dense as some of our things, and people tend to pay attention to the law. So maybe they sort of self-protect. So here's what's happened, and I'm going to share my screen and show you. So this comes from a website called 91divok, which uses publicly available data. It's my favorite website for COVID-19 information. And here you can see, this is what I picked is, this is normalized by the number of population. Blue is Sweden. Purple is Italy, right? We know the terrible catastrophe in Italy. Brown is all of Europe. And this is sort of time. And look at the animation. Hopefully you can see this. Now look at the animation. So the infection starts, Italy increases. The measures start working and it starts going down. And now look how Sweden is starting to climb, right? And you can see these little dots, right? So when everybody else has recovered, Sweden still has a really high rate of infection and an unnecessary rate of infection. Now, I want to take away Italy because it's so much higher than the others. And I'll show you sort of the countries that are equivalent. So Finland, Norway, and Germany. And actually take away the average of Europe also. And now look at this animation. So they all seem to go relatively together. And then at a certain point, all of them go down and Sweden keeps going up. So if somebody tells you that the Swedish experiments work, you can tell them, yeah, the Swedish experiment tells us it did work. It showed that if you incorporate shelter in home, masking of the population, isolation, you prevent this disease. Now, if you look at Denmark or Norway, right, here's the thing, borders are open, right? Well, they're not open right now, but these are countries that are really similar in population density, genetic admixtures, economics. In theory, they should have had the same exact outcomes, but they didn't. And the only difference was this early shelter in place. And if you look at mortality, it gets really crazy because there's no people dying in Norway of COVID-19 anymore. You can't get the numbers. This is Sweden. This is, let's see, this is Germany. This is Finland and Norway. And really, it's all almost zero. So again, if you're looking at it, you can see mortality goes up and up and up. I can add Italy in a second, so you'll see the big difference. But Sweden, although mortality has sort of gone down, I think part of it is just the fear of people. So again, if somebody asks you or has doubts about the effectiveness of lockdown, undoubt that this is effective. The same thing is in the US. So what you see here is red is Connecticut, purple I think is Massachusetts, orange is Arizona. So again, in the US, we're spread apart, right? The infections happened mostly in the West Coast and then in the East Coast. West Coast, because of this early hit in Washington, Seattle, actually there was a much stronger enforcement. But if you look at it now, you basically see how this whole thing starts in Massachusetts. Massachusetts and Connecticut go really similar because they all get infected because of New York. And then there's sort of two bumps, but we're going down. And if you look at this, I'll actually, just to make it clearer, this is Connecticut, and you see it goes down. This is the crazy situation when I was worried and I couldn't go to sleep at night because I didn't know what will happen the next day. Will I have enough drugs? Will I have enough ventilators? It goes back. So here's where, the isolation started, I think, here. Oh, no, here. And then 14 days later, you start seeing an effect. Again, still limit, then a big decline, and then the widespread of use of masks, and then sort of a big steep decline. And again, now we're sort of at the sort of what you may call a stable situation, not zero yet. And then you see the states that have been a little bit lax, and definitely Arizona is here, Texas is here. And what I wonder is, and this is the average of the United States. So clearly, if all of the United States follow the same rules, we would have seen a decline. I'll show you something I'll just highlight the highest hit states. And just one more. And then again, we're going to animate. So you can see how this whole thing is really driven by the infection in New York, then New Jersey, then Connecticut, Massachusetts, almost like geographically makes sense. New York is leading, New Jersey coming in, Connecticut is coming in. Then you start to see the effect of the lockdown in place. And then you sort of see these increases in Texas and Arizona. So people have asked me, what is the impact of the reopening? And frankly, I will be very honest and say, I don't really know. I was following the numbers from, and again, I'm not an epidemiologist. I'm like all of you, just looking at, I know my statistics and I like numbers, but it's not like I have a clue. So this is today. 14 days ago, right, 3 weeks ago was Memorial Weekend, right? So that's when the state started opening in Connecticut. And we had this slowdown, and actually this doesn't seem to have affected us much. So that's 3 weeks ago. Maybe we would have gone down like this, and maybe this sort of bump here is the result of the reopening. We don't know yet. This is where the big demonstration started, and I was in Connecticut, in New Haven. There were 5,000 people demonstrating very, very peacefully. We didn't see anything that's happened in other places, despite the fact that people closed down the I-95 for a few hours. The city, the state were really supportive and made sure. So it could be that the fact that we didn't continue going down here is a late result of this. I don't know. And then we kept going down, and again, we're stable. This could be, again, a late impact of the 14 days. But we don't see this sort of the increase, right? And the main reason, I think, is very simple. Although demonstrations are probably a higher risk of infection than many other things, 99% of people, at least in the demonstrations in New England, were wearing masks. Actually, our physicians, our emergency room physicians, went out to the demonstration and handed out masks. And when I went to, actually 2 weeks ago to the demonstration, I actually had a big pack of masks. And it's New Haven, so, and it was on the green, walking. So basically the demonstrators were all had masks, but there were a few homeless people on the green that didn't have them. So I handed them out, and I think they appreciated it. I don't know what they did with it. And I think that the masks, the big breakthrough is the mask. So if you have to do a public activity, if you have to go to somewhere, you need to mask yourself, and you need to make sure that people around you have masks. Now remember, a surgical mask gives you limited protection from being infected. We don't know exactly the number. You may say 50%, you may say 70%, but it's not 99%. If the other person is wearing a mask, your likelihood of getting infected, if two people are wearing a mask, the likelihood of getting infected goes down to really 1%. So if the two people are wearing a mask, the infection rate goes down dramatically. There was this piece in CNN about the two hairdressers that were infected with COVID-19 that wore masks. They did extensive contact tracing, 220 people. None of them was infected. Doesn't mean that it's perfect, and they may have not been the super shedders, but it definitely reduces the risk. So if you have to go out, be in an area of people that respect the law, wear masks. There are other ways to protect yourself. There's better masks, right? So the known thing is the N95. So the N95 is basically a mask that is a filter. It prevents you from breathing particles. The first time I think I used an N95 outside of the hospital was running or biking in London. Didn't really help me, but there's actually recommendations sometimes in London and other cities that are really polluted to wear masks when you're running. You do need probably tighter masks like the N99. The problem with the N95, one is that there's different brands. Not all of them are as good. So the 3M brands is really good. There's a couple of Asian brands that have sort of CDC stamps and FDA stamps, but are good. The other issue with N95s is false sense of security, which is if you don't wear them, good. If you are not fitted, if the shape of your face doesn't perfectly fit them, there's still maybe some chance of infection, especially if you stay long enough. So even if you wear an N95, probably it's good that the people around you wear a surgical mask. Another option that's really important is face shields. So I actually think that people who work and interact with a lot of people, like cashiers and bus drivers and other things, probably the best thing for them is to wear a face shield and a surgical mask. Face shields reduce the infection rate to very low, almost zero. It has a benefit because you can take off your mask if you're eating something and you're still relatively protected for a few minutes. And so, but this is sort of the three layers of defense. There's of course also real respirators. You don't need this for, definitely not for COVID-19, but also for other things. Here's an interesting thing. So, and that's a family observation. And I don't know, I would love to hear if people think the same way. So again, my mother lives in Israel. She's now 88. And every year, wintertime is sort of stressful for us because she'll get a bronchitis, she'll get an infection, she'll get this annoying cough. Then she gets an antibiotic, then she gets some side effect. And she's really smart and gets it. This year, since March, everybody who gets in contact with her have to wear a mask, and she wears a mask. She didn't have a single episode of bronchitis. Added benefit that we don't think of. And again, if you have a chronic lung disease, and I actually say it to patients sometimes, and with IPF and definitely with COPD, is hug your grandchildren, but if they have the sniffles, maybe don't hug them, right? You know, protect yourself. So I know it's hard, but it's true for all viral illnesses in a sense, because many of them could be a risk. So just to answer the question of the masks, is again, surgical masks, you protect others really well, you protect yourself less well. So the most important thing is that the people around you wear a mask. N95 will give you much better protection. So if you're in a high risk situation, and then face shields are also could be an alternative if you have to attend an event that's really important for you emotionally, that you're willing to take the risk. So that's another way, is important. What about physical distancing? So everybody speaks about the 6 feet thing. I don't really know where this comes. You know, it makes a lot of sense based on the models. If you're in a closed space with no good ventilation, I don't know, you know, distance will reduce the number of virus hitting you, which will reduce the severity of disease. But it's not the real protection. Outside, if you're outdoors, 6 feet, I think is good. I still recommend wearing a mask. Part of it is just to get used to it. Now, there are specific impacts to patients with pulmonary fibrosis. So a surgical mask doesn't really affect your breathing. It may affect the way you feel about it, but it doesn't affect your breathing. And N95 does affect your breathing, and it increases the resistance to your breathing. It doesn't affect your oxygen level, so there's been a lot of misinformation about it, but it increases your resistance, your respiratory effort, and especially for patients with IPF, with restriction, this is an issue. So that's why probably avoiding this sort of, you know, again, if it's a 5 minute risks, you need to do this. And if it's a patient who's oxygen dependent, who needs oxygen, the best thing is actually test yourself, right? So the first time you put the mask is not when you go to the supermarket. You put the mask on at home, put on your pulse oximeter and see what happens, right? But be aware that N95 do increase the effort of breathing, right? Other things, I think maybe we can open up for questions if people want to start asking questions, and I can stop my share.
Yes, Dr. Kaminski, one of the things that, you know, we hear positive and negative things are about the possibility of using hydroquinoline, wait a minute, however it's pronounced, that drug that, you know, some people say you can take it prophylactically, or if you got infected, you know, make sure the doctors give it to you. But everything I've read is like it really isn't, you know, helpful. So what do you know about that?
So hydroxychloroquine is a drug that we actually know a lot for many years because it existed as an anti-malaria drug for years. And we also now give it as an anti-inflammatory to patients with lupus and some other conditions. So we really know the risk profile. There's two side effects that are really important to hydroxychloroquine. One is it changes the heart rhythm. And basically it changes a specific area in your ECG that we call QT, it doesn't matter. And by the way it changes, it increases the probability of having arrhythmias, right? And not just regular arrhythmias, these are lethal arrhythmias. Now, what we know now is that some parts of the population, and you would not know it if you have never had an ACG or this, actually are predisposed to these arrhythmias. You can live for the rest of your life and never have an issue. But if you take a drug that prolongs your QT, you may have this side effect. So hydroxychloroquine is dangerous. This is not something you take without a physician giving it to you, right? That's the first thing. And you need to have an ECG before, and you need to have an indication. The second thing is, we usually only prescribe drugs that do something, right? So, well, every now and then, you give a patient a drug and say, oh, I don't know what will it do, but maybe it helps you. But then we do it in a very limited time and look at it, right? Our own experience in IPF is actually steroids. I was a huge opponent of the times that people used to treat patients with anti-inflammatory drugs in pulmonary fibrosis. And actually, when I was the director of Simmons Center, me and Kevin Gibson, who was my second in command, really were against it. And then we had a trial. And when the trial was being designed, and I have to give a lot of credit to Fernando Martinez, who sort of drove the trial, there were people who said, so we wanted to do a trial of anti-inflammatory drugs in IPF. And Fernando wanted to do it. Many people said, but you cannot give anything, right? How can you ethically not give the patients a drug? But he insisted on doing anti-inflammatory drugs against placebo. And then we charged the middle of the trial, they started seeing that the people who got anti-inflammatory drugs died more. Nobody expected it, right? This was a big change. Now nobody with IPF gets the prednisone azathioprine. And that's why I think actually patients look better and feel better, right? So the same thing is with hydroxychloroquine. Sometimes you think it may be logical, you think it may be safe, but it's not. Currently, no trial has shown an effect for hydroxychloroquine in COVID-19. What we do know, there was a trial in Brazil in which they tested high dose versus low dose, and actually their low dose was higher than what we use. And in the high dose, people were dying. They had to stop the trial. So this is a dangerous drug. Now, I'll be honest. So when you are in a situation that you have limited information, sometimes you take chances, right? So at Yale New Haven Hospital and Yale, when the disease were already picking up, we decided that we will have a protocol. And the discussion, we formed a group that was called Advanced Therapeutic Groups and a clinical group. And the idea was that we are not going to deprive our patients from drugs that there's no information about them. And we accept that we're working in a situation with limited information, but the idea was everything will be protocolized and we will be committed to change the protocol quickly, right? So initially, actually, hydroxychloroquine and azithromycin were in our protocol for almost a few weeks until information. Now, we looked at our data in real time, all the time. We didn't see a signal for excess mortality. We did not see. So patients were not killed by this therapy, but they were not benefiting. And the other thing is, there's a huge difference when you do it in a hospital with a monitor, with an ECG, with thinking about all the other drug-to-drug interactions, and when you do it like at home or a prescription. I was shocked to discover that some lupus patients could not get a prescription for hydroxychloroquine in Florida because there was no hydroxychloroquine. Concierge physicians and others just gave it to a lot of patients. So although the numbers of COVID-19 cases in Florida were not that high,
and the numbers of deaths are not that high. They're increasing now. We don't know how many people, even if it's a small number, just died at home in their sleep with an arrhythmia. That they'll never show up on the statistics, right? They didn't have COVID-19. You know, it's still an older population. This happens, right? And if there's no required notification of the drugs, you don't know. So I think that this is really important, dangerous. Don't take hydroxychloroquine unless you have malaria and your physician gave it to you, unless you have lupus. Very simple. And again, I do acknowledge that our instructions have changed over the time, even in the context of our hospital. And, the treatment protocol for COVID-19 for Yale New Haven Hospital has been public. We put it online every time it comes up. We decided we're not going to hide anything. And but we change it almost 2 or 3 days, every 3 days. So it's interesting. And but the main thing, and actually the coolest thing, because we decided, to change the protocol, and because we decided to have a real protocol, not that every physician decides what they want. One is, of course, it helped us. We had hundreds of patients. Just imagine every young physician, every older attending, they have their own biases. We didn't want to be in a situation that one person gets X and the other person gets Y. And we also didn't want the insurance level, the race, the ethnicity of the patient, other things to impact care. So everybody got the same thing. If you had the same complaints, you got the same therapy. And I think this was a sort of a big marker of our success.
Dr. Kaminski?
Yes.
What do you suggest we do about appointments like dental cleanings? Our dentist has a scheduled for the end of June when they think that their office will be actively seeing patients again. So for we, the PF people, what do you suggest for that?
I think one is it depends on what region you are, right? Because some regions may have less the other. The other thing, you do have to ask, what are the active protections, right? They should share with you what they're doing, actually, to protect you. And may I say, nobody has died from postponing their dental cleaning by a month, right? But I do think that there has to be an open discussion about it. I think the chances of getting infected currently, right now, in medical office are really low, probably 0. But again, you want to ask, and frankly, if you don't feel, they should wear masks even on regular appointments, right? I don't think anybody has seen a dentist not wearing a mask in the last 10 or 15 years when they take care of you. But you want to ask a little bit more. And if you're not confident about the type of answer, or you just postpone it. The problem is we don't know what will be the safe zone, and it depends on the regions in the US. Mm-hmm. Like, the increase in Arizona, the sort of shifting in Texas, several regions are sort of climbing up now. So we don't know necessarily how it's happening. But you want to remember with healthcare workers is that they're more afraid than you are. Because you are one person interacting with one person. They're one person interacting with 100, right? So there's a good chance that they'll keep on. But again, if they don't have the PPEs, and I would ask them, and I don't even know, again, I don't want to throw this idea. I don't know whether there's a good chance they'll be using face shields because much of the cleaning is aerosol generating. So I don't know about that.
Okay. Thank you.
Dr. Kaminski, may I ask a question about herd immunity? Um, when you were speaking before, were you saying that herd immunity only takes into account vaccination, and without the vaccination, we cannot expect to have herd immunity?
No. What I'm saying that the correct use of herd immunity is the context of vaccination. Okay, because not in the context of vaccination, nature takes precedence. So, there's going to be 50% mortality or 25% mortality or even 1% mortality is really high, right? So if you look at some of the states that were really hit, we had a 1 in 1,000, 0.1% overall mortality, right? That's infected and non-infected. So that's a really high number. So we wouldn't want to live in a situation that, 1 in 1,000 people will die every day in the next year or two to reach herd immunity. That's what I mean.
So you said if nature takes its course, it's going to be a painful road to herd immunity.
Exactly. And if you think about, like when people speak about economy, so it's not like if the pandemic is raging, economy is not going to survive, regardless if you lock down or you don't lock down, right? So that's the point. But the right use of herd immunity is in the context of vaccines, because the threshold is around 70 to 75%. If 75% of the population has gotten the vaccine and developed antibodies, the other 25% are also protected.
Thank you. And just one other quick question. You mentioned that masks seem to be the most effective measure. So let's say we mask up, we face shield, and everyone else is masked. Pretty good protection, right? But if we go out and we go grocery shopping, we're touching things, we're coming in contact with things. What do you recommend we do when we get home? As far as, not touching things, what do we do with the masks?
This is a brilliant question, because one of the things that I discovered is that it's really hard to communicate sterile technique to a non-healthcare worker.
Yeah.
So as a physician, I got socialized to it, right? In med school, actually, I worked in med school because I needed to work to make some. I worked as a nurse, right? So I actually worked first as a bartender and then as a nurse. But so you get socialized into clean thinking. And I think I saw it with my wife. It's very hard for her to understand the separation between a dirty area, a clean area, and how you do it. And I think it's really hard. Several things. One is the chances of actually bringing infection on your clothes are really low. Most of the infections happen either through direct breathing, so that's aerosol, and some of it by droplet. We don't know the extent. I've been wondering about it, and actually I thought nobody has asked me whether patients with chronic lung disease should go with gloves on, or, to the supermarket. I don't know that that's effective. I think we have data to show that washing your hands really gets rid of the virus the 20-second rule works. My suggestion is, if you have to go out, if you're out in the air, not a big issue, right? The two things that you want to do, but if you have to go to the supermarket, to a big event, I would still, when you come back home, the first thing you want to do is make sure that you're not getting anything from your hands on your face. So the first thing is wash your hands, right? Then take off your mask. And again, I'm not an expert. I'm just speaking based on intuition, right? Put the mask, if you're going to reuse it, put it in a place that you're not going to reuse it within the next few hours, right? Usually we think that you can reuse a surgical mask, for a week, but if you were in a dirty place, probably that's not a mask you want to reuse. You could leave it in the sun for a few days and it will probably be okay. But again, I don't know. Your cloth mask, if it's a dirty place, you probably need to wash it. When when I used to go into the hospital, I would actually change in my office and not, carry the sort of the dirty clothes, although I don't think they were dirty, basically in the back. But it's not, I don't have a good answer, right?
Okay. What I worry about with people, like you mentioned, hand washing. So if you're in the A&P, you don't have the opportunity to hand wash. And I worry not so much about, people coming to and from a place. So I live in New York City, and public transportation is a nightmare, right? So one thing we recommend is that, you mentioned gloves. So yeah, it's probably not more effective than hand washing, but we recommend that people put on, let's say, 3 pairs of gloves. So now I'm touching everything here with these gloves, but I have an itch on my nose. It's uncontrollable. I could take one glove off, throw it away, and now I have a clean glove.
Yeah. So, this brings me the memories of, actually, when I was a med student, I was in New York in 89. It was sort of the height of the plague, AIDS, the half of the hospital was AIDS.
Yep.
We knew already what was the root of infection, but there was a lot of fear. I still remember there were all these urban legends, like that's the equivalent of internet now. They said that there's going to be infected needles in the public payphones and all kinds of crazy stuff, right? But the truth is that was one of the things that we did. This comes from the AIDS days, the two or three gloves approach, right? I think, actually, I think masks really help you with preventing touching your face. Actually, it's a huge benefit. And by the way, I would like to mention to, again, patients with IPF, if you're going out, put a surgical mask or put the glove over it. You get the double protection. And that's exactly, it's the same thing that you did. It's another layer of protection so you don't touch things by mistake. The other thing is ordering stuff. Again, there's a whole YouTube on how you create a clean space in your home and separate the grocery and stuff. The truth is that the risk from these things is low. Right. But you have to pay attention. Now, if you live in New York and have IPF, I hate to say it. I don't know how to say it in a polite way, but still avoid the subway. I don't know how to do it. But I don't know what you think about it. But I have I actually think that if there was a universal masking law in New York in the subway in March, we probably don't end up with the catastrophe we ended up.
Agreed.
Dr. Kaminski?
Yeah.
Is there any data about how people with IPF who have contracted COVID have done? Any data or any statistics about COVID in people with IPF or PF?
No, we don't have yet. We don't have the data. We have the data on autoimmune disease with no lung disease. They did actually better. What we don't have, I think what happened is I think some of the patients chose not to go to hospital or chose to take an end-of-life type of route, so we don't really know. And I think that's...
Dr. Kaminski, you've been so gracious with your time, but we're approaching that kind of a 90-minute window, which is a long time for anybody to speak, as much as you'd like to speak. So I'm going to ask you if we could have about 15 minutes to kind of more or less wrap up and ask questions, please. This is a rare opportunity for all of us to ask questions that are top of our mind about COVID, about pulmonary fibrosis, about interstitial lung disease. And I know of nobody better to ask than Dr. Kaminski. So for 15 minutes or so, let's do that. And then Shelley can wrap things up.
So actually, I want to do one clarification because somebody asked me about the numbers. So the data I showed was normalized per 1 million of population. So it's the number you look at is much lower than the actual number. if you want to know the numbers for Sweden now on day 98 is over 1,000, 1,300 patients per day. And that's a lot for a small country. So basically the numbers that I showed, if you looked at the website, I showed the version that is normalized to the size of the country. So the numbers don't really reflect the overall numbers.
Say, doctor, do you have any warnings for us on the use of public transportation in general, such as buses, planes, trains?
I have no clue. I can tell you that's more the advice I give my family, which is avoid it, right? If you don't have to, right? I think the other thing is it's really good to not travel right now because one is you want to be close to your physicians and your care team, right? It's really bad to be in a city that you don't have the right connections if something goes on wrong. I don't know about, I'm actually surprised that airlines are not taking more security. In theory, you could sterilize a plane between rides very easily with UV light and a few other things, but I would take, if you don't have to travel, really don't. And I think it also helps, one of the things that helped us definitely in the Northeast is because of the shelter, we didn't have the big trauma cases, right? So one of the reasons that our hospital could focus on COVID-19 is because we didn't have the motor vehicle accidents we usually have on I-95, right? We didn't have, so I think avoiding travel, again, unless you have to, is good. About buses, in theory, if they just open the windows on buses, if everybody wears a mask, you probably are okay, because then air just flows. But I think most of our buses nowadays, not like even when I was a kid, you can't open a window anymore. But again, it's hard to say. People are dependent on public transportation. It's really difficult. What I would say is the most important thing is actually take a walk, right? So weather is getting better, but it's also getting hotter. Really important to keep your joints moving, your mood. So a short drive or a short bus ride to some park and walking around is really good for you. But I don't know about trains. Yeah, I would avoid unnecessary travel still.
Dr. Kaminski, how about going to an exercise place like a clean YMCA? If you wear a mask and gloves, that just for 30 minutes or so, I miss my conditioning.
Yeah, I don't know about that, right? It's exactly the same thing. It's like, I'm trying to push, like we have a hard time because our pulmonary rehab is closed, right?
Yeah.
This is really terrible, right? Because it has a direct impact on the health of our patients, right? If people are transplant candidates, if they need surgery, anything. So this is a big problem. I don't really know. I hope that some of the facilities will have good clarity of but I would avoid anything the next couple of weeks though. It depends also where you live, right? But I think this sort of unstable area now that we don't really know how infection rates is heading, this sort of huge increase in Arizona is a concern. So I would, and the other thing is, of course, speaking with the gym, especially a YMCA, they'll be, instead of asking them what are they doing, right?
If I can make a comment, I'm the director of a pulmonary wellness center in New York City. We've been closed since March 10th. because it's huge risk for our patients. And the thing is that it's getting to and from the center that I worry about most. So, we've always, utilized tremendous cleaning, practices. But I worry about my patients getting to and from the center, taking the bus, taking, the subway. I recently did fly. I recently flew from New York to LA and back. And I wanted to see for myself what it's like. So I can, and I can tell you this, I was happy to see that they were taking very good precautions. I still took my own precautions, but there's a lot that could go wrong, and it's like, you can't control all situations. And that's the issue. So we developed an online pulmonary wellness program because we don't want people coming out. The risk is that, we're not talking about you're going to get like a hangnail. The risks are very high and the stakes are high. So protect yourself.
Yeah, I think so too. And I think, again, that things are getting clearer now. Almost every week we have a better feel, despite, there's a problem with a lot of disinformation, but I think we're getting a feel. Some places, like one of the things we're looking at the pulmonary rehab is basically having a lot of plastic around. So basically all treadmills are going to be separated from each other. But turns out that you need actually to replan your ventilation if you're doing it. So one of the things that I learned, because people are now coming back to work in the labs, and although they're supposed to be 6 feet apart and wear masks, I was really concerned because there has been reports, especially in restaurants, because of the way ventilation goes, there's a hot area that all the virus lands, right? And you never know it, right? So turns out that actually our research building, because of the risk of exposure and chemical things, is basically always sucking the air up very slowly, not creating turbulent space. So in theory, if you're sitting in one place, you'll never breathe the air of somebody who's a few feet away from you. Most gyms are not like this. Most gyms actually have a circular ventilation, aims to prevent the smells and everything else. So actually, there is a risk there. So it may be good even to speak with the thing if you want to go back. But there's definitely still a risk.
Dr. Kaminski, is there any data that you know of to show if there's more of a likelihood of getting COVID if you are an IPF patient versus just the general population? Are we at more risk of getting it, or is it the same for everybody?
We don't really know. And I actually, there's no data about the risk. The receptor for the virus is slightly higher in the lungs. That's unpublished data. Is slightly higher in the lungs of patients with IPF than regular. I think the age risk is bigger than the disease. Right, so we know that the risk of having severe disease with COVID-19 really dramatic increases over 65. So I think that that's probably a bigger issue. And the same thing, I'll say the same thing. I mentioned my family. I've been really, with all my aunts and mother and everything, I said, you don't take any chances, it's not worth it. Right.
Yeah, understood. I think I'm going to revert back to age 25.
Yeah.
Dr. Kaminski?
Yes.
I have a question. So the vaccines that are coming out and they're being tested, I see a bunch of them saying about the T cells and how they're going to work on patients with somehow through the T cells. But as a transplant patient, we take CellCept, which is a T cell blocker. So what is the future going to look like for vaccines with transplant patients, in general, but definitely with transplant patients? What is that going to happen?
So you hit the nail in the head. That's why that's where the concept herd immunity comes in.
Right.
So if 75% of the population will take the vaccine, the people with transplant don't need to worry. right?
Yeah, but no one, like, there's all these anti-vaxxers that are not going to want to take it, and then what am I going to do?
And it's the truth now, and it's the truth for, you know, we see it with influenza, we see it with H1N1. I don't think there's a good solution. One of the vaccines, the RNA vaccine, may work better just because of the way it does it, but we have no clue. So they will actually have to test it in immunosuppressed hosts in parallel. There is a silver lining for people after transplant. And the silver lining is that our impression was that people who are slightly immunosuppressed actually did better on COVID-19. And the reason is that the virus, the way the virus does two separate things. One, it causes injury directly to some cells, but the other thing, it induces this inflammatory response that actually magnifies the injury. And people who are under some immunosuppression actually don't develop this inflammatory response. So again, you don't want to, I would be very careful about laying my bets on this, but actually when we looked at it, people with immunosuppression, and it's an impression, it's not a statistic yet, did actually slightly better. And actually we've used immunosuppressive therapy in the patients with COVID-19.
Oh,
Routinely, yeah. So there may be something, a silver lining there, and that's a difference. So if you think about influenza directly kills the cells. COVID-19 induces an inflammation that then kills the cells. So if you can sort of interfere there, so that's the thing. But again, the vaccine is going to be, we'll see. But the main thing would be we need the population to take up vaccines in general. You know, and this year actually, influenza is going to be critically important in general, because if there is a bump in COVID-19, we need to at least not have a lot of people with flu in the hospital.
Yeah.
So somebody asked about the blood types. So that's a very interesting thing. And I think it has to do, one of the complications of COVID-19 is coagulation. There's a difference in the tendency to coagulate on different blood types. So I think there is an overlap in this effect. So it seems like the people who have blood type O have a less tendency to develop complications with COVID-19. Again, this needs to be reported because many of these observations that you see, even if the big journals, and you read about them in, you know, New York Times or whatever, they're all retrospective and they may be affected by other factors, right? And sometimes factors we don't know about. So again, it's hard to know if the blood type is really protective, although there seems to be that the people with O blood type are slightly less susceptible to the severe complications of COVID-19.
Doctor, I have a question. Can you hear me?
Yes.
Whenever we get to the point where we have a vaccine, do you have any advice on whether people should be early adopters, or should we wait a little while and see if there are any side effects? I just hearken back to some of the early flu vaccines, you know, that were live vaccines, I think, that caused some problems. So what's your advice there?
So one is, you know, there's going to be multiple trials. So I think we will know the safety, the early safety of the vaccines we'll know very quickly. The late effects, side effects, that's very hard to know. You need millions and millions of people to be studied. I think that probably better not to be an early adopter if you have a chronic disease. because every small change in balance could affect you in a way that's unpredictable, right? Yeah, so unless there is something very obvious, right, that comes out, I would, you know, you need to make sure you got your flu vaccine. If you have Shingrix, and definitely the pneumonia vaccines. But I would be a little bit, I would wait a little bit before thinking about it, just because, again, even, remember, we don't know even if the impact of the mild symptoms, you know, sometimes after flu, you will have a flu-like syndrome. We know now it's really safe for a patient with IPF, but it's hard to assess with this. So I would not advocate that. And the other thing also, remember, so early adopters should be people who get exposed a lot, and hopefully IPF patients prevent exposure. Yeah,
Dr.
so
Kaminski, you've been so gracious with your time, and we appreciate it. But we have time for one more question. Then reluctantly, we have to let you get back to the real world and your family and the things you normally do. And thank you one more time. And just a quick announcement that this interview, along with others, we're relaunching our website sometime next week or the week after. At that time, Dr. Kaminski's interview will be online, as long as some gifts and special offers we will have for our members that we're very excited about. You'll be hearing more about it this next week, so keep your eyes open. And so we have one more question, and then we're going to fade.
So Bill, can we ask something? If everybody's willing to put their face on video, and you maybe can take a screenshot of the whole gallery of everybody that participated, is it possible?
He's muted.
You're muted, Bill. There, Patty's getting it.
I'm talking to myself here. We'll make sure you get a copy of this, Dr. Kaminski. And one more time, you're awesome is the only word I can describe. And you deserve being a PF warrior, which you are, by the way. And I'm very, very proud to let our other members know that you've been highly supportive of us and give us guidance and inspiration. And I want to thank you so much for that as well.
Yeah, glad to help. And you know, we want to eradicate pulmonary fibrosis, right? Cure IPF.
Cure IPF. Definitely.
Well, with that, we're going to close down. Thank you one more time, Dr. Kaminski, and I'll make sure you get a copy of this, and everyone here will have access to the video in about 2 weeks.
Okay, my pleasure. Thank you.